Good morning, everyone. I am Dr. M.I.M. Shuja, lecturer in physiology, Faculty of Medicine and Allied Science, Respiratory University of Sri Lanka. Today's our lecture topic is regulation of respiration. This is again one of the very easiest lecture to understand if you know the basics very clearly. If you know the basics, you can work it out, then this is going to be easy. Okay, trust me, this is going to be very easy lecture. Yeah. So the regulation of respiration. So these are the learning outcomes. You can go through that. So there are two kinds of respiration. One is spontaneous respiration. Without our knowledge, we are respirating. We are inspiring, we are expiring without our knowledge. But sometimes, imagine if you think, yeah, now I'm going to inhale deeply. You can inhale deeply. That is voluntary. So the respiration has both voluntary and involuntary control. Okay. There are muscles responsible for inspiration, expiration, and there are accessory muscles as well. The rhythmic discharge to motor neurons, because you have to give some impulse to the motor neurons, then those neurons go and act on the respiratory muscles. Depend on nerve impulse from the brain. It also regulated by alteration in arterial partial pressure of oxygen and partial pressure of carbon dioxide and hydrogen ion concentration. There are few supplemented non-chemical influences also there. So mainly we can divide the control of breathing into neural control and chemical control, but both are interconnected. So first we look into neural control. In any control system, you will have a sensor, because what is happening should be sensed by your sensor. Then those sensors will send message to your central controller, your brain. Then your brain process it. Then it say to your muscle, the respiratory muscle, okay, now have a deep breath in. So like that, there are three components: the sensor, central controller, and effector. So the sensors are chemoreceptors, lung and other receptors. The input is goes to the central controller, pons, medulla, and other part of the brain. Then output comes for your effectors, respiratory muscle. This is the basic element of control. Today, we are going to concentrate more on the sensors and central controller. The central control is, you can divide into basic two things: the basic control and fine control. The basic control of respiratory rhythm originates from three neuronal groups within the medulla oblongata. Pre-Botzinger complex, we call it pacemaker of the respiration. Dorsal respiratory group, we tell it DRG. Ventral respiratory group, we name it VRG. So hereafter, if I say DRG, that is dorsal respiratory group. If I say VRG, that is ventral respiratory group. They are set of neurons. So these are mainly for the basic control of rhythm origination. Then you have to tune up that, the fine tuning. That control is by pneumotaxic center and apneustic center. So we will go one by one and we'll see what are their functions and we'll see how they are integrated. So respiratory center in the, this is your medulla. Sorry, this is your pons, this is your medulla. In the pons, you have pneumotaxic center and apneustic center. In the upper pons, you have pneumotaxic center. Lower pons, you have apneustic center. In the medulla, you have DRG and VRG as well, both single complex. So there are two separate neural mechanisms. One is voluntary, other one is automatic. The voluntary system is mainly located in the cerebral cortex and it sends impulses to the respiratory motor neuron via cortical spinal tract and it acts. The automatic system is driven up by pacemaker cells in the medulla. Impulse from these cells activate motor neuron in the cervical and thoracic spinal cord. Then it activates diaphragm, then external intercostal muscles for the inspiratory drive. So mainly the central controller, the respiratory center, is located in the pons and medulla. And we saw what are the centers located in pons and medulla. They send output via respiratory neurons to the phrenic motor neurons that mainly supply your diaphragm, external intercostal neurons and internal intercostal neurons. They supply intercostal muscles. So in the medulla, you have the inspiratory neurons and expiratory neurons. We call it I neurons for inspiration, E neurons for expiration. I neurons are located in the dorsal group of neurons or DRG, dorsal respiratory group. E neurons are mainly located in the VRG, ventral respiratory group. E neurons fire just before and during expiration. So what does that mean? I neurons for inspiration, E neurons for expiration. So there are other respiratory centers. The inspiration by DRG, expiration by VRG, pneumotaxic center and apneutic center. So here there are a few connections. The pneumotaxic center inhibit apneutic center. Meantime, it inhibit your inspiratory group. Apneutic center stimulate your inspiratory group and there are negative feedback, inhibition between inspiratory and expiratory because at a time only either inspiration or expiration. So there is a internal internal inhibition between inspiratory and expiratory neuron. So now I am coming to give you additional information. So listen very carefully. This is your pneumotaxic center. Pneumotaxic center is a fine control of the respiration. Because when you are doing respiration, you inspire and you expire. Inspire, expire. The transition from inspiration to expiration is controlled by pneumotaxic center. That's why I told you, because the pneumotaxic center has to do the transmission from inspiration to expiration. So it has to inhibit the inspiration. So that's why here the pneumotaxic center inhibit inspiratory group. Then apneustic center. Apneusis is you are taking a deep prolonged breath in. That is apneusis, prolonged deep inspiration. That is done by apneustic center. So the apneutic center is controlling or stimulating inspiratory neuron. Where you have inspiratory neuron? In the dorsal respiratory group of neurons. Okay. But the pneumotaxic center is inhibiting the apneusis center. So usually there is no prolonged inspiration. But if damage occurs in the pneumotaxic center, there will be no inhibition to the apneusic. So there will be prolonged inspiration occurs. Then the pneumotaxic center control DRG and VRG. Apneustic also control that thing. This is central chemoreceptors. They control or they stimulate or inhibit DRG. So now I hope you got a clear idea about what is pneumotaxic center, what is apneustic center, what is DRG and VRG. Then inspiratory RAM. So inspiration is mainly from the dorsal respiratory group of neurons, so DRG. The RAM signal means so initially there's a low action potential, low amplitude and low inspiratory signal. With time, high amplitude, gradual increase and the high depth of inspiration that we call inspiratory RAM. It's characterized by steady increase in the amplitude of the action potential. Okay. The RAM signals are not produced continuously, but only for a 2 seconds, during which inspiration occurs. After 2 seconds, RAM signals are stopped abruptly. Suddenly they stop. They do not appear for next 3 seconds. So that is the time where your expiration occurs. And at the end of the expiration, again, RAM signal reappear. That means normal inspiration is 2 seconds, normal expiration is 3 seconds. Usually, what is the center responsible for the transmission of inspiration to expiration? Pneumotaxic center. Okay. So this is inspiratory RAM we have gone through. The normally during inspiration, DRG group of neuron inhibit expiratory neurons. I told you earlier, there's the inhibition between inspiratory and expiratory neurons. During expiration, the expiratory neurons, DRG, inhibit the dorsal neuron, that is inspiratory neuron. Thus, the medullary respiratory centers control each other. The medullary respiratory centers control each other. The respiratory centers in the pons, they control the medullary respiratory center. They said the VRG, that means expiratory neuron centers, does not appear to participate in the basic rhythmic oscillation that controls respiration. They are important in providing powerful expiratory signals to the abdominal muscles during very heavy expiration, because expiration is normally passive. So this is what I have explained so far. You can just go through. Now we will look one by one. Inspiratory center. So tell me where the inspiratory center is situated. What is the name? DRG. Dorsal respiratory group of neurons. So how to remember is ventral is expiratory, dorsal is inhibitory. Sorry, dorsal is inspiratory. So I remember that is VE. V is the term you will learn in the third year. It's the abbreviation for vaginal examination. It comes in the gynecology. So VE, V, ventral group for expiration. So other dorsal for inspiration. That's how I remember. So inspiratory center is by dorsal. There's a nucleus tractus solitarius is there, and it mainly contains eye neurons, that is inspiratory neurons. Then these axons, they go and terminate in the motor neurons of the phrenic and intercostal nerves because they supply inspiratory muscles, diaphragm and internal intercostal. Expiratory center is, I told you, ventral respiratory group, but this is having both in I and E neurons. So expiratory center is having inspiratory neuron as well as expiratory neuron. It is inactive during normal quiet breathing because expiration is a passive process, I told you. However, it's used in forceful breathing because forceful breathing will have a good expiratory component. Then the function of this is it generally causes expiration but can cause either expiration or inspiration depending upon which neuron in the group are stimulated. It sends an inhibitory impulse to the apneustic center because apneustic center is for prolonged inspiration and this one is sending inhibition for the apneustic center. So prolonged inspiration is reduced. So you have time for expiration. So now we know what are the two centers inhibiting apneustic center. One is pneumotaxic center. Other one is expiratory center. Okay. This is how we will ask MCQ questions. Okay. You should be very thorough in and out in these centers. What are the type of neurons? What are the function? What they are inhibiting and by what they are getting stimulated. Okay. The pneumotaxic center, it's located in the pons. It also contains both E and I neurons. It controls both the rate and pattern of breathing. It limits inspiration. The pneumotaxic center, it's sending negative impulses or inhibitory impulses for the inspiratory group of neurons. So here in this graph, this is sending inhibition. So however, the exact function of the pneumotaxic center is unknown, but people believe it play a role in switching between inspiration and expiration. Fine control. I taught you. When it is damaged, the respiration becomes slower and tidal volume greater because when it is damaged, the inspiration is too much. So tidal volume is greater. That is we call apneusis, prolonged inspiration. Apneustic center is again in the pons lower part. Its function is it discharge stimulator impulse to the inspiratory center. That is obvious, we know. it discharges an inhibitory impulse to the expiratory center because it needs to have a prolonged inspiration. It receives an impulse from pneumotaxic center and the extra receptors of the lung. The pneumotaxic center is in the upper pons. Respiratory rhythm. The pacemaker of your respiratory control is pre-Botzinger complex. Okay. It is situated between the nucleus ambiguous and lateral reticular nucleus. The nucleus ambiguous and lateral reticular nucleus we will study very deeply in your neuroanatomy and neurophysiology. For the time being, just know where pre-Botzinger complex is situated and what is its function. Then neurons of the pre-Botzinger complex discharge rhythmically. We know that is the pacemaker of the thing. Then neurons in the pre-Botzinger complex contain NK1 receptors and mu-opioid receptors. Therefore, substance P stimulates and opioids inhibits respiration. But it can be modified. Even though the rhythmic discharge is mainly from the medullary neurons, that means spontaneous respiration, it can be modified by the neurons in the pons, your apneustic and pneumotaxic, and afferent from the vagus and receptors in the airway and lung. Stretching of the lung during inspiration initiate impulses in afferent pulmonary vagal fibers. They come and inhibit inspiratory discharge. So the depth of the inspiration is reduced. But if you done vagotomy, there is the vagal nerve is cut, the inspiration, the depth is increased. That is an common MC. So now we'll go for a summary. You have pneumotaxic center and apneustic center in the pons, and you have the DRG and VRG and pre-Botzinger complex in the medulla oblongata. The pneumotaxic center is mainly switching between inspiration and expiration, fine tuning. Apneustic center is for prolonged inspiration. So when there is the pneumotaxic center, it is having a inhibition on apneustic. So when there is a damage to the pneumotaxic center, you will have prolonged inspiration. That means increased tidal volume, but the respiratory rate is slow. Then these control DRG. Pneumotaxic center inhibit DRG. Apneustic stimulate DRG. And there is a inter-inhibition between DRG and VRG. Simple. You should be able to say what are the function of these centers, how I express. Then marking MCQs is like a walk in the park. Then these DRG and VRG both having inspiratory neurons. They will send impulses to the spinal cord, cervical and thoracic level. From there, the motor neurons goes to the diaphragm and intercostal muscle. So inspiration is happening. So when the activity of inspiratory neurons increases, the rate and depth of breathing increases. How? I have given you the answer as well. You can go through that. Both the rate and depth is increased when inspiratory neurons fires. So that is central control. So I told earlier, in control we have sensors, central controller and effector. Now we have finished the central controller. Now we come for the sensors. So usually there are receptors which sense. When these partial pressure of oxygen, partial pressure of carbon dioxide, hydrogen ion all are in the blood, you have chemoreceptors that sense. Okay, collection of cells that are sensitive to the chemistry of the blood, that is chemoreceptors. They are located in the medulla, that means your brain, central nervous system. So we call it central chemoreceptors. And few chemoreceptors are located in the abdominal, sorry, not ab, sorry, aorta and carotid arteries, especially the carotid bodies and aortic bodies. So we call that peripheral chemoreceptors. And in some other part of the body, there are few chemoreceptors available. The chemoreceptors are stimulated by a rise or increase in the arterial partial pressure of carbon dioxide or hydrogen concentration. These hydrogen concentration either due to the carbon dioxide or maybe due to your metabolic acids. And it is again stimulated by a drop in arterial partial pressure of oxygen. Then these stimulus or they initiate impulse and that in turn goes in stimulate the respiratory center. Then the respiratory center responds. So now we are going to look how these chemoreceptors are acting. You have the peripheral arterial chemoreceptors and central medullary chemoreceptors. The ventilation is adjusted so that alveolar partial pressure of carbon dioxide is held constant. Excess hydrogen ion in the blood is combated or compensated. Partial pressure of oxygen is raised when it falls to dangerous level. Idea is to maintain good PO2 level and reduce excess PCO2 and H+. The both type of receptor, that means both peripheral and central receptors are sensitive to changes in the hydrogen ion. Both receptors are activated by increase in partial pressure of carbon dioxide, that is independent of hydrogen ion concentration. Acute hypoxia, sudden reduction in the partial pressure of oxygen, is mainly stimulate your peripheral chemoreceptors. Okay, but maintain hypoxia, that means a prolonged hypoxia, can depress both central and peripheral chemoreceptors. So this point is very important. Acute hypoxia stimulate peripheral arterial chemoreceptors, not the central. Now we look into carotid and aortic chemoreceptors. There are carotid bodies and aortic bodies. Carotid bodies are found in the bifurcation of the common carotid artery. Once they simulated, once they initiated, they send impulses via the glossopharyngeal nerve to the central respiratory controller, your brain. Aortic bodies, they are found in the arch of aorta and pulmonary arteries. Once they are stimulated, they send impulses to the central respiratory controller via vagus nerve, that is cranial nerve 10. Okay, there are total 12 cranial nerves. We will learn that during the neurophysiology and neuroanatomy. But remember, the 9th and 10th cranial nerves are functioning here. So this is just a graph saying the aortic arch, you have aortic body, you have carotid arteries, you have carotid body. So here we see this is your left ventricle, your aorta, it's aortic arch, you have the aortic bodies here. Then this is your common carotid artery, it bifurcates into internal and external carotid. At the bifurcation level, you will having the carotid body. Okay, not the carotid artery and aortic artery stimulated. The carotid body and the aortic body is stimulated by changes in the partial pressure of carbon dioxide, oxygen, and hydrogen ion. Now we'll see how this change happens. It's a wonderful physiology. So listen very carefully, fasten your seat belt and be alert. So here, if you look at the carotid body has two kind of cells. One is glomus cells type 1 and type 2 that we call sustentacular cells. These are supportive cells. Glomus cells type 1 is very important because it is having a potassium channel and dopamine is found in vesicles like the presynaptic neuron. You have acetylcholine in the vesicles. Here it has dopamine in the vesicle. It has the potassium channel for potassium efflux. Are you all okay with that? Usually it is oxygen sensitive potassium. Okay, I'll come to that later. Okay, so usually this is the structure of the glomus cell in a diagrammatic view. Now, when there is a reduction in the oxygen, that is partial pressure of oxygen less than 60 millimeter mercury, or increase in the H plus, that is reduction in the pH, or increase in the carbon dioxide. The carbon dioxide diffuse into the cell, convert into bicarbonate and H plus. This H plus, this H plus, and this H plus is from carbon dioxide. This H plus is from metabolic acids. Okay. These three, reduction in the oxygen, increase in the H plus, will inhibit these potassium channel. So the potassium channel is inhibited. So potassium cannot goes outside the cell. Potassium cannot efflux. Efflux going outside. When the potassium is cannot goes outside, what will happen? The positivity inside the cell is increases. So it is causes a kind of depolarization, partial depolarization. With that partial depolarization, calcium channels are activated. So via these calcium channels, calcium from the outside of the cell will comes into the inside of the cell. When calcium comes, what happens? These vesicles goes and release dopamine to the neuron, which is outside the glomal cell. What are these neurons? Cranial nerve 9 and 10. So They send impulses via cranial nerve 9 and 10 to the central controller. Okay, this is the just a bird eye view of what I have explained. And this is peripheral chemoreceptors, carotid body and aortic body. So mainly reduction in the partial pressure of oxygen stimulate peripheral chemoreceptors. But of course, increase in the partial pressure of carbon dioxide also stimulate. But 70% of that stimulated carbon dioxide is, sorry, the 70% of increased carbon dioxide stimulate central chemoreceptors. Only the 30% stimulate peripheral. But mainly peripheral chemoreceptors are stimulated by reduction in the partial pressure of oxygen. So now we are going to see what I have been explained. There are two types of cells, type 1 and 2, surrounded by fenestrated sinusoidal capillaries to get a blood supply. The type 1 or glomus cell, it resembles adrenal chromatin cell, have dense 4 granules contain catecholamine, dopamine is a catecholamine, receive cup-like endings of the afferent nerve. Lots of sinusoidal capillaries which have a very large blood flow. Type 2 cells are just supportive. This is a diagram you should know to draw this and explain. Very simple, isn't it? The glomus cell, they excited by hypoxia and cyanide, have oxygen sensitive potassium channels. The conduction of the channels is reduced in response to hypoxia. So it leads to the excitation of afferent nerve ending. So oxygen sensitive potassium channels, because of hypoxia, reduce potassium efflux. It depolarizes the cell, that is partial depolarization. So it activates L-type calcium channel. So calcium ions coming inside the cell, it triggers the action potential. It releases the neurotransmitter dopamine. Dopamine goes and excites the afferent nerve ending. Because the blood flow per tissue, per unit tissue is high for the carotid body, the oxygen need can be met by the dissolved oxygen alone. Because usually, if you have 100 milliliter of blood, you get 15 milliliter of oxygen and 5 milliliter is getting used. This is 2000 milliliter. So the diffuse oxygen, even though in 100 milliliter, the diffuse oxygen is low. But in 2000 ml, it is comparatively large. So that enough to needs the carotid oxygen need. Therefore, the receptors are not stimulated by anemia because the dissolved oxygen is enough. Methemoglobin. What is methemoglobin? I taught you in the last lectures, go through that. And carbon monoxide poisoning. Because in the carbon monoxide poisoning, the dissolved oxygen is normal. Okay. So these three will not stimulate peripheral chemoreceptors, the carotid and aortic bodies. Stimulation results from a decrease in carotid and aortic body tissue oxygen, which will occur with arterial hypoxia, that is decreased partial pressure of oxygen, especially less than 60 millimeter mercury. And ischemia, from marked hypotension, you don't have enough blood supply. They are also, these carotid and aortic bodies are stimulated by an increase in tissue partial pressure of carbon dioxide more than 10. Usually it is 40. If it is sorry, further increased by more than 10, it gets stimulated. If there's a decreased tissue pH, the pH is decreased more than 0.1 to 0.2 units, and cyanide poisoning and drugs such as nicotine and lobeline, they all stimulate carotid and aortic bodies. So the effects of chemoreceptor stimulation includes, so there's a problem in your PCO2, PO2 level, is the carotid and aortic body gets stimulated, it sends the message to the central controller in your brain. So it's going to give some effect. How? It increase respiratory rate and depth. So increase oxygen, wash out of carbon dioxide. The carotid body, if they stimulate, they cause bradycardia. Remember your baroreceptor reflex. Aortic body stimulates, it got tachycardia. And hypertension due to peripheral vasoconstriction and bronchoconstriction all happens. The peripheral chemoreceptors are responsible for all the ventilatory responses to hypoxia. In their absence, the decreased partial pressure of oxygen depresses respiration due to direct effect on the brain. Complete loss of hypoxic drive has been seen in patients with bilateral carotid body resection. Okay, the carotid body, not the aortic body, responds to increase H plus. Okay, the carotid body is responding to increased hydrogen ion concentration. So this is just because we need a break during the lecture, because it's a kind of complex lecture people believe, but in my point of view, it is very easy. I hope you all found easy so far. For a break, I want to give you some a philosophy. Success demands. Success does not need something. Success demands. Success will ask. Okay? Hard work. Patience. Be patient. Your time will come. Sacrifice. Consistency. Be disciplined. Have a proper attitude. Success follows. And have self-confidence. Believe I can do. You all are champions. All the 210 students are champions. So I trust on you. I believe on you. You believe on yourself. Then you will all pass the exam this time. No need to worry. Okay? Hopefully every single one of you going to pass the exam. Okay, so far we have seen what is peripheral chemoreceptors and how it's stimulated and act. Now we are going to look into the central chemoreceptors. They are located in the central part of the brain. The effect of carbon dioxide on central chemoreceptors. Okay. The blood-brain barrier is impermeable to both hydrogen and bicarbonate. However, carbon dioxide diffuses easily through the blood-brain barrier. Blood-brain barrier is the kind of like your alveolar capillary endothelium. It is a barrier between the brain and the other organs. But carbon dioxide diffuses easily through the blood-brain barrier. Carbon dioxide which enters the brain and CSF is promptly hydrated. So it becomes carbonic acid, and that carbonic acid is dissociated into local H plus and bicarbonate. So the hydrogen ion is increases, so it decreases the pH of the CSF, cerebral spinal fluid, which subsequently increases the ventilation. So this is carbon dioxide in the vessels. So in the blood vessels also, carbon dioxide forms carbonic acid and it becomes H plus and bicarbonate. But the H plus and bicarbonate cannot cross this blood-brain barrier. Only the carbon dioxide process. So increased carbon dioxide crosses the blood-brain barrier. Inside the blood-brain barrier, it becomes hydrated, become carbonic acid. The carbonic acid dissociates into bicarbonate and hydrogen ion. So increased hydrogen ion due to the increased carbon dioxide reduces the pH. These increased hydrogen ion stimulate the central chemoreceptors. Okay, so we have keep that here to make the graph, the diagram easy. But in the medulla you have central chemoreceptor regulatory area. Then it gets stimulated. It again stimulates DRE. What is DRE? Dorsal regulatory group of neurons. Those are for inspiration. But again, these stimulate VRE because even though VRE is for expiration, it also has inspiratory neuron. So when there's a too much of increase in carbon dioxide, that is hypercarbia, increase in H plus, it stimulates both DRE and VRE and increase the inspiration. So increase the ventilation, respiratory rate. Okay. The effect of carbon dioxide on respirations are mainly due to its movement into CSF and its increase in H plus. It stimulates chemoreceptors and there's a H plus increase. Sorry, I'm having a very bad cough. Whenever there's a increases in the H plus in the arterial blood, it increases ventilation. How? The metabolic acidosis due to diabetes mellitus, increase in H plus, it goes it goes and increase respiratory rate. That is deep labored ventilation we call metabolic acidosis. Small breathing you will study during, I think, endocrine physiology. The hyperventilation because there's an increase in partial pressure of carbon dioxide, your respiratory rate is increased. So ventilation is hyperventilation. So the carbon dioxide is washed out. So there is a reduction in the hydrogen level. Usually the arterial partial pressure of carbon dioxide is maintained at 40 millimeter mercury. If there's a rise or increase in the partial pressure of carbon dioxide because of the increase in tissue metabolism, because the end product of tissue metabolism is carbon dioxide. Ventilation is stimulated, carbon dioxide is washed out until the arterial partial pressure of carbon dioxide fall back to normal. This process is tried to or helps to keep carbon dioxide in balance. So there's a linear relationship between respiratory minute volume and the alveolar PCO2. The graph is linear. But the linearity has an upper limit. When the partial pressure of carbon dioxide in the inspired gas is close to the alveolar PCO2. Usually in the inspired gas, carbon dioxide is low. But if it is similar to the alveolar carbon dioxide, same as 40 millimeter mercury. There may be a difficulty of diffusion of carbon dioxide from your blood to the alveoli. So there is a problem in elimination of carbon dioxide. Elimination of carbon dioxide become difficult. At that point, even though your body is hyperventilating, it is difficult to reduce the carbon dioxide. Okay. So at that point, the alveolar and the carbon dioxide pressure in the artery begin to increase despite hyperventilation. This hypercapnia depresses. Hypercapnia means increased partial pressure of carbon dioxide, depresses central nervous system. So you will get headache, confusion, and if it is not resolved, it leads to coma and eventually brain death. So this is the linear relationship between partial pressure of carbon dioxide and ventilation. When there is too much of alveolar, sorry, when there is too much of alveolar oxygen, the ventilatory effect is low. When there is reduction in the oxygen, the ventilatory effect is high. There is a little response until partial pressure of oxygen become less than 70 millimeter mercury. Marked response occur between or below 50 to 60 millimeter mercury. The response is enhanced by increase in partial pressure of carbon dioxide. The carotid and aortic bodies account for the increased ventilation from acute hypoxia. You see, when there is a reduction in the partial pressure of oxygen, the ventilation is increased. And that increase is again supported or further enhanced by increase in the carbon dioxide concentration. So whenever the low oxygen, the ventilation is increased to pick up more oxygen via increasing your respiratory rate. But if the partial pressure of carbon dioxide also increases, the ventilation is further increased. Then there are few non-chemical influences on respiration, like inflation reflex, deflation reflex, J receptors, proprioceptors, baroreceptors. So inflation reflex we call it Breuer reflex. When you have too much of inflating your lung, there's an overinflation causes reduction in the respiration or inhibit the inspiration to prevent your lungs from blast. Okay. They respond to excessive stretching of the lung during large inspiration. Like Breuer deflation reflex. And you have the J receptors in the pulmonary vessels. When they are stimulated by hyperinflation, they send message to the central nervous system, central control area. The reflex response is apnea followed by rapid breathing, bradycardia and hypotension. Okay. They are innervated by C fiber. From this, we can ask you a true false or single best question MCQ. So don't study and think only the central controlling, peripheral chemoreceptors, central chemoreceptors are important for the exam. Every slide in this lecture is important. Okay. Then proprioceptors. During the active and passive movement of the joints, there are proprioceptors in the joints and the tendon and muscles. and they stimulate and helps to increase ventilation during exercise. Okay? Because during exercise, you need more oxygen. To get more oxygen, you have to increase your respiratory rate. So, these proprioceptors stimulated during your active and passive movement and send message to a central controller saying this chap is doing exercise. We need more oxygen. So increase respiratory rate. That's how the reflex is happening. And baroreceptors. When the carotid and aortic baroreceptors stimulated, that means if the blood pressure is increases, ventilation is coming down, the BP is going down, ventilation is going up. But these effects are little important in regards to physiology, but in point of MCQ, these are important. And reflex from somatic and visceral tissues, like the ventilation increases during cold water, during pain, during emotion, the ventilation increase. Okay, so the reflex from somatic and visceral tissues also plays a part. And both inspiration and expiration are also under voluntary control. I told you initially. The pathway for the voluntary control passed from the neocortex to the motor neurons, innervating the respiratory muscles while bypassing the medullary neurons. Medullary neurons are mainly involuntary control. And this is the summary of regulation of respiration. And with that, we come to the end of the wonderful and, in my point of view, one of the most easily understandable concept. I hope all of you understood this thing. If you have any doubt, you can send me a WhatsApp or you can contact me via email. And there are two questions to just go through and work it out. They are true, false, MCQ type. And I always say, may peace be upon you. And thank you very much. Have a nice day, my students.